sir. Good afternoon, sir.
Hi, good afternoon.
We are live, please.
Good afternoon, everybody, and a warm welcome to this module 9 of Progression Control Certification Program, which is being run by AIUS. And at the outset, I would like to really thank Dr. Namita Sharma ma'am for giving us all an opportunity to work on this and to have this particular certification program for myopia control. So a very, very warm welcome to all of you and to all the panelists and experts and presenters. I would like to introduce Dr. Abhilasha. She's head of Department Pediatric Ophthalmology, HV Desai Eye Institute, Pune. So I would just ask her to introduce the speakers and start the session. Thank you, Abhilasha.
Yes, thank you, sir. Good afternoon, everyone. First, I would like to sincerely thank Team AIS and Dr. Jethani for this opportunity, and I extend my heartfelt gratitude for conceptualizing this thoughtfully, executing this initiative towards creating awareness and academic engagement also through this module. So, as we have discussed in previous modules about how to slow down the progression, it is equally important that now that burden is already there, how to associate and how to address other implications like myopia, associated complications in retina, strabismus, or cataract. So let's see now explore these dimensions with our eminent speakers and expert panelists. I will welcome our expert panelist. First, Dr. Kirti Singh, Director, Professor Glaucoma Services, Guru Nanak Eye Center, Maulana Azad Medical College, New Delhi. Dr. Meenu Mathan, Senior Consultant Cataract, Chaitanya Eye Hospital and Research Institute, Kerala. Dr. Love Kochgave, Pediatric Ophthalmologist, Director, Netralaya Super Specialty Eye Center, Kolkata, West Bengal. Dr. Amit Porwal, Senior Consultant, Head Glaucoma Services, Chaitram Netralaya, Indore, MP. Dr. Sangeeta Sekaran ma'am, Senior Consultant, Department Retina, MN Eye Hospital, Chennai, Tamil Nadu. Has Dr. Chinmay joined, sir? Yes. So I'm moderating this session with
She will join shortly, I think.
Yes. No worries. Okay. So today I'll be moderating this session with Dr. Chinmay. She's currently pursuing the fellowship in pediatric ophthalmology at Baroda Children Eye Hospital at Gujarat. So let me introduce our speakers. So our first speaker is Dr. Anurag Mishra, Director, Radharam Eye Hospital, Cuttack, Odisha, and he'll be speaking today with the very relevant topic, that is cataract and myopia. Do you want me to introduce all the speaker initially, sir, or we will go ahead?
Yeah, please go ahead.
Yeah. So our second speaker, Dr. Arpita Agarwal, Consultant in Glaucoma, Cataract and Refractive Services from the Asia Hospital, Bhopal, MP. Our third speaker, Dr. Divakant Mishra. It's a pleasure to introduce all the speakers. He's a director, Swanjyoti Eye Hospital, Lucknow, UP, and as we all admire him as the president of EOC. Dr. Digvijay Singh, a pediatric and neuro-ophthalmologist, director, Noble Eye Care, Gurgaon, Haryana. All these eminent speakers, I'm looking forward to the all academic feast today. So without any further ado, I would request Dr. Anurag Mishra. Over to you, sir. Kindly share your screen and let's start the discussion.
You all able to see my screen and hear me loud and clear?
Yes.
Yeah.
Okay. So, good afternoon, ladies and gentlemen. Greetings and regards from the land of Jagannath. Thank you so much, Abhilasha, for a nice introduction. Thank you so much, Jeetu Bhai, my mentor, my guide, my teacher, who had a massive contribution in making me what I am today. Thank you, AIOS, for this honorable opportunity to talk in front of a knowledgeable audience and experts like Love, my friend, and Meenu sir, who I always look up to when I want to learn something new on cataract. So there are reasons why an ophthalmologist or a surgeon should be happy when a patient having a cataract walks into the office. And there are more reasons why a surgeon should be happy when that patient walking into the office with cataract also has high myopia. The reason the first instance makes the surgeon happy, the reason the second instance makes the surgeon happy is because the myopia and the cataract can say or bid farewell to the patient once and for all in the same sitting. However, to be able to do that, we need to understand a few pearls in the IL power calculation, which includes biometry and certain surgical tips as well. But before we dive into both of these segments or any of these segments, let's understand the problem statement first. Amongst the population of myopia, it's been estimated that 1.5 to 4% of the patients are affected by cataract or they develop cataract at some stage of their lives. Progression of myopia is an associated risk factor. It's something that increases the risk of developing cataract fast. Nuclear cataract is the commonest morphological form, which is followed immediately by posterior subcapsular cataract. And as we have found out, they quite often coexist, which in fact is something which is the reason actually why the myopia contributes to index myopia. The myopia keeps on increasing. The patients unawares of this, particularly those who do not come to consultants or doctors or eye hospitals to check their eye power, keep on changing their glasses without realizing that it's the index myopia which is increasing and not the actual length of the eye. So often the presentation is late because these are pure nuclear cataracts and they do not affect the vision till they reach a grade 5 or a grade 6er. The pathogenesis of cataract formation in myopia is this. There occurs a vitreous liquefaction and the oxygen saturation increases locally, which downregulates the antioxidant genes present in the lens. This is the same pathogenetic mechanism that works in cataract formation in post-vitrectomized eyes, and this also contributes towards cataract formation in high myopics. All right, so let's look at the biometrics. This occurs. Oftentimes, the patients present with a previous history of laser vision correction, RK, which is not commonly practiced now, of course, and phakic. So that becomes an additional thing which needs to be tackled at the same sitting. The biometric nuances will be divided into several segments for our convenience. We'll discuss a few things about the axial length measurement, astigmatism correction, the pupil size, aberration of the whole optical system, and then finally, what are the inputs we receive from getting an anterior segment OCT done, which to me is actually a must when you're dealing with atypical cases, high myopics being one of them. When we take the patient off for axial length measurement and ask him to sit before an optical biometry, the saving grace is, since we mentioned seconds back, that they present late because vision doesn't get affected till it's really, really late in terms of nucleus sclerosis grading. The saving grace is the fixation for near is good. So when you ask them to fix on a target inside the equipment, the fixation is good. So the measurements are usually compatible. Optical biometry has to be done. There's no second thought on that. And previous technologies like the coherence technologies, the partial coherence interferometry or optical low coherence reflectometry techniques or technologies were inferior to the standard SSOCT technology that we have in the market now. So it should be done with a machine which employs the SSOCT technology. I have access to 3 of them. This is the ILMaster 700, the gold standard optical biometer machine in the industry. This is the Argos, and this is the Antirion coming in from Heidelberg. The ILMaster 700 uses a wavelength of a light of 1050 nanometers. This uses 1060, and the Antirion uses a 1300 nanometers wavelength of light, which is thrown into the eye. Why I mention this is because longer is the wavelength of light, along with the Hertz energy that it emanates, the brighter the source of illumination, the attenuation rate of the light rays while they are traveling to hit the center of the fovea is less. more is the axial length, more is the propensity of attenuation. So if you have a bright light, which has a more wavelength than the other instruments, the attenuation of the light energy before it reaches the fovea is less. So you have a stronger reflected ray back from the center of the fovea, and the axial length measurement is more accurate. So as a consequence of this, higher the wavelength, meaning it should be the anterion, number one, followed by the Argos and the 700. However, in my experience, the Argos actually yields the best axial length, the most accurate axial length for measurement in cases of high myopics. The accuracy goes up with increased penetration, as we discussed, and reduced attenuation. Now, the ILMaster 700 has got another problem. It's a faster scan. It's a much faster scan than the other scans available in the industry. What it yields, therefore, in myopic cases particularly, is less accurate readings. It has a telecentric keratometry, so before you even bring it to the focus, proper focus into the cornea, it does take the keratometric readings, which is not something that's very good because the slower scans always yield more accurate readings than the faster scans. And when the axial length is more than 26, even if you do not get any warning signals from the machine, any signal or any sign that this reading might not be accurate, it's always a good idea to take multiple readings, maybe on the same day, but multiple readings with the same machine at intervals of around 10 or 15 minutes, so that you just know that all the three readings match up with one another and the readings are accurate and you can take them. You can accept them. For astigmatism correction, keratometry should be taken at close to 3 millimeters. So in my opinion, again, the Argos scores over the other because the ILMaster 700 takes the 2.6 or 2.8, and this takes at 3. Topography for the orientation of the meridian should be done in all myopics, particularly if the meridian, one of the meridians, is seemingly steep. Wavefront keratometry should be looked at wherever possible if you have access to one. And this is particularly important for post-LVC, arcade, dry eyes, keratoconus, and all that. And the EKR map on Pentacam should be looked at if you have a post-LVC patient who seemingly needs an astigmatism correction. Let's look at some of the more interesting examples. This is one example drawn from the eye trace. Now, if you look at the top end here, the refraction calculated by the ray tracing technology here will show you that the refraction is around minus 1.5. But if you look at it down below, the astigmatism is around minus 2. So what happens here? The keratometric astigmatism or astigmatism at the cornea is being somehow managed internally. If you look at these maps on the left-hand side, you will know the difference. This is the corneal astigmatism, where you can see that the vertical meridian is steeper. The lenticular astigmatism or the internal astigmatism shows you that the horizontal meridian is steeper. So somehow the corneal astigmatism is being neutralized partially by the internal astigmatism. So when you remove this lens, perform cataract surgery, the patient would need a much higher toric trim to neutralize the corneal astigmatism than the glasses would suggest. So it's never, the glasses the patient is using is never an indicator as to correcting the astigmatism at the corneal plane. The anterior segment OCT also shows us signs of zonular laxity or subluxation, and this is one crucial indicator drawn from the ASOCT, vertex scleral spur angle. There's one line that is drawn from spur to spur. There's a perpendicular line drawn to the corneal vertex, and the angle between them is judged. And then you know that it's here, it's written as 4 degrees. The 4 degrees is the angle between this yellow line, which is through the vertex, and the orangish line, which is drawn through the both scleral spurs, joining both scleral spurs. So if it is more than 8 degrees, you do suspect a lenticular subluxation or an internal subluxation of the lens. This is the EKR map, one sharp spike. This cornea is regular, and we can jolly well go ahead and put in a toric to correct the astigmatism. If it's not that way, then we have to be careful. The pupil size in myopics is often higher than normal, and it should be measured dynamically, particularly when you're planning presbyopia correcting IOLs. The aberration profile also might change with the change in pupillary size. We'll look at an example a little while later. But it is a good idea to judge the pupillary size at the maximum scotopic and the maximum mesopic pupil sizes. So the maximum dimension to which it can dilate and constrict under physiological conditions. And if you look at the pupillary size measurements, the ASOCT again gives us the best pupillary size, followed by Pentacam and other machines. So if you have access to an ASOCT, always trust it to give you the best pupillary size. You can change the ambient lighting in the investigation room to mimic the mesopic or the photopic or the scotopic conditions and thereby measure the pupillary sizes. Aberrations are particularly important for post-laser vision corrections. All higher order aberrations and the Q value. The Q value is on the negative side, as we know, when there's a hyperopic LASIK, and positive side when there is a myopic LASIK vision correction. And accordingly, you can plan the IOL, whether aspheric or spherical. And if aspheric, then how much should be the negative asphericity in that particular product? And should also be looked at in all patients with attempted PC-IOL. This is true for all patients, not only myopics. So this is the example I was talking about. Look at this patient. The pupil size out here is shown to be small, and the aberrations are pretty much acceptable. They do not look like it's a distorted image at the pupillary plane with the ray tracing. But in the next image, when the pupillary size increases, look at the aberration profile now. It is showing a coma, as the arrowhead suggests. It is also showing a spherical aberration. So both of these being added on. So this patient, if receives a trifocal under mesopic conditions when the pupil dilates slightly, will be finding it difficult to drive. So this is one patient wherein trifocal should be avoided. Again, a myopic patient. The ASOCT, as we discussed, gives us these indications. Additionally, it can also give us the lens thickness so that you prepare yourself when you take the patient through the OT. These are the choices for the IL power calculation in myopics. SRKT with Bangkok, Barrett's toric calculator, Barrett, the Keynes formula, EVO, Hill RBF. In my hands, in my modest experience thus far, the Barrett's calculator always works the best. There's only one catch in there if you have a post-LVC patient. There again, you have multiple choices, Barrett's True-K, Kane, EVO, the Hoffer QST, which has come up recently. The ESCRS website gives us a good recommendation as to which formula to be used. But there are red flags in this. As I have found out of late, I'll just give you one prototype example. This was one patient who had come in. I put all the values in the ESCRS. Very surprisingly, even if you can see the K1 and the K2 clearly showing a delta of around 2 diopters here, none of the formulae, EVO and the Hoffer QST, the two formulae that the ESCRS recommended, none of them showed me the necessity of putting in a toric, and the spherical equivalence was also shown to be 0. I put these values into Kane. The Kane showed me a T4 requirement of a T4 with a 15 diopter spherical power of an IOL. Then I put it in the Barrett's True-K, which showed me a 16.5 with the same T4. Ultimately, I stuck to the Barrett's True-K, and the patient's doing very well. This has been 8 to 9 months, is standard 0 residual refractive error. So in my opinion, the Barrett's True-K still works the best. So to concise all we have discussed thus far, the aim for myopia with cataract should be around 0.5 diopter on the myopic side on absolute spherical counts, but the cylinder should be corrected fully. If you have lower order aberrations left, one lower order aberration is always better than two. So if it's a composite myopic astigmatism, then the distortion in the image front is always more. Trifocals, if you're trying to implant them, the first hyperopic part should be taken. But in my experience, sometimes I take the second hyperopic part, wherein the absolute spherical error is around plus 0.25 to plus 0.3, because what I've observed is all because of the higher pupillary size of the hyperpupillary dimension of these patients, the halos that are produced on the retina front is always more. Okay. So this is about the IL power calculation. We'll just quickly go to the surgical chronicles. These are the things that we need to have in the trolley ready. Iris hooks for meiosis, CTR implantation tools, long and sharp chopper, because sometimes they present with really, really hard nuclei, new tip and sleeve wherever possible so that they cut through the nucleus like butter, and the multi-piece arsenal, both calculated for sulcus placement or the back. And when you don't have any formula to calculate the sulcus placement of a multi-piece, you can employ the rule of 9 as is the gold standard. Sometimes the patients come with this nystagmus, myopic patients. So therein you need to fix the globe. The way I fix the globe is through the side port incision blade and not a forceps, but it's your choice. You can put it any which way you like. Sometimes while doing the rexis, you feel a drag on the capsule. That's when you should know that the zonules are not exactly the strongest. And if you do not have the strongest zonules, this is the way you should perform the hydro, a multi-quadrant. Look at the fluid injection here. I'm not piloting the nucleus. I'm not pushing it back to the bag to express excess fluid. I do it in the end when I see the fluid wave. And once the hydro is complete, I always am a proponent of implanting the CTR early. Because if you have a generalized zonular dehiscence, then it is always better to support the equator right at the beginning so that the zonular dehiscence does not progress. And believe me, it does not come in the way of your surgery at all. For combating a breathing pupil or a reverse pupillary block, as we call it, the second instrument can go in and lift the iris slightly before the phaco needle goes in so that the reverse pupillary block doesn't happen, causing any pain to the patient. Now, usually these cataracts are hard, and one set of parameters that I would always request, and I'm sure Meenu sir would agree with me, is performing surgery under low fluidics. Look at the right-hand side tiles on your screen. The IOP is set at 20. The aspiration flow rate is at 26, and the vacuum is at 450. This is an unedited video which will be shown to you. If you can see down below, one of the tiles will show you that the fluid inflow into the eye is around 26 cc's per minute, so that it doesn't cause any reverse pupillary block, as a result of which it doesn't liberate prostaglandins and doesn't cause intraoperative miosis as well, till we finish off and come out. This is the last page which is coming out here. Since these eyes have a lot of space inside, if you're liberating more fluid, causing more fluid turbulence, it can hold more fluid, thereby causing somewhat of an assault to the corneal endothelium, which is very sensitive not only to the energy bang on it, but also the fluid bang. This is another case wherein the cataract was really, really hard and really leathery, but nothing changes on the fluidics parameters. You still go ahead and do it under low fluidics conditions. And when you do that, the chopping and the other steps are performed with equal efficacy. However, you do not bombard the eye with fluid. This always happens when you're trying to put the IOL in. The moment you take in the irrigation cannula, the pupil expands and the eye deepens. But when the IOL goes in, the moment it touches the iris, the pupil again comes down. However, it's not very difficult to put in the IOL through a small pupil. You can just dial the rest of it in. So I'll just like to leave all of you with a few tailing pearls before signing off. The residual refractive error post myopic cataract surgery should always be an absolute negative spherical power with the cylinder completely corrected as much as possible. The CTR's efficacy should be weighed in individual cases. Some people recommend implanting a CTR in a myopic patient wherever you have the requirement of a toric IOL. I don't support that view because A, if you are putting in a CTR, then the anterior and the posterior capsule come very close to one another because the equator is stretched. This effectively changes the ELP, and you might just have a myopic shift immediate post-op or a myopic drift later on. So all cases do not need a CTR. The efficacy should be weighed in individual cases. The IOLs which you choose should and must be hydrophobic acrylic, because these patients are very, very likely to develop PCO post-operatively if you have implanted a hydrophilic IOL, because the contact with the posterior capsule in very high myopics, whatever IOL you put in, is less than a normal patient because it is so much posterior. So it is likely to be less. So it's the best you can do is put in a hydrophobic acrylic, which has a square edge. The best you can do to ensure the capsular non-proliferation. The design should be modified C-loop. Strictly, I avoid plate haptic, the fenestrated loop haptics, plate haptics, the tetraport haptics, the triport haptics, the open C loop, dual C loop designs, they don't work as well as the modified C loop does. And it should be without an optic haptic angulation. Some lenses have an optic haptic angulations, the optic sitting backward to the optics around 5 to 10 degrees. So what happens therein is post-operatively, after a few years, when there is an equatorial constriction of the back, it puts pressure on the haptics and the optic starts moving forward, causing a myopic drift again. Since we have already left this patient slightly on the myopic side, more myopic drift might not be very acceptable in the long run. So I would always prefer an IOL which does not have an optic haptic angulation. That's all in this edition, ladies and gentlemen. Thank you so much for the opportunity again. Here I sign off. Thank you.
Thank you, sir. Thank you so much for the wonderful presentation. Now we'll open up the panel discussion. May I ask Dr. Minu Mathan to contribute his insights on this topic?
Yeah, thank you. Thank you
Sir,
very much,
over to
Jitendra.
you.
Yeah. Can you hear me?
Yes, sir.
Yes, sir.
Yes,
Yeah,
sir.
thank you. Thank you, Jitendra. Thank you, Anurag. So when Anurag presents, it is almost always complete and very exhaustive, and to the what should I say? It will, and internationally it will be top notch. So
Thank you,
I
sir.
was thinking what I should tell after this, but then all these newer optical biometers are very good and they are supposed to be used, but many of us may not have access to this one. And so, if you please look for a posterior staphyloma, whether a patient has a posterior staphyloma or not, and then look at your scans. If you do an ultrasound immersion, look at your scans and the peaks there and make sure that is coming exactly from the retina. That is one thing you can do. And if they are experienced people, you can very well get good axial length values. And topography is one thing which many of us will have, and definitely I would suggest a topography also. And the formula, I am very much happy with the Barrett Universal 2 and the Barrett Toric and all those. And so I've been, even today morning, I saw one patient, both eyes, one IOL power is +2, and the IOL other power was -1, and patient is nil glass. Patient is nil glass, and only near vision correction alone. So, and we are getting very good results with the Barrett toric calculator, and that's right. And the use of corneal tear substitutes before you do a K reading, in especially people who have MGD, is very crucial here, because we don't want to have an error in keratometry, because you are likely to get an error in the axial length, but you should not be having it in the keratometry part also. And they should be made aware. When he was telling about people coming later, when they come with early nuclear sclerosis, what I do is I take a picture of their lens and show them that this is getting colored, and colored, this one will become harder. And it is not that your vision will go down drastically, but your surgical complication is going to increase as you are already having a compromised eye. And also they will also realize it by the increase in the myopia which they are getting. And we need to tell them that both the two visits itself, your axial length is going to be the same, and your power is increasing just because of the lens turning cataractus. And so they should be encouraged to have this. And I have seen young people getting bilateral retinal attachment after cataract surgery, just because the proper pre-op evaluation is not done, and regular post-op, immediate post-op, regular reviews are not done with retina clinic. So if you know how to do good indirect, well and good. But I usually send to the retina specialist so that they can take a very good look pre-operatively and tell them very clearly that your periphery is not fully examined. We have to see you as early as 1 to 2 weeks post-op, dilated, to see your retina again and treat if possible. See, some patients think that it was not there pre-op, and after surgery your retina is torn, you have a hole there, you need to do laser. So this kind of counseling is very important for high myopes who are very highly possible that they'll have it. And if they're having it, and then if it's possible to laser, I will definitely do laser and then do. But some are too dense to have a laser, so we do it after the procedure, immediately after documenting it very clearly that this is required for you. And during surgery, some people will be very sensitive to pain, and we may have to block. So a subtenon's block will be the best to do. Avoid needles, but there are anesthetists who are very used to perivalvular blocks and they're very good at it. And so you just have to avoid going very close to the globe. And nowadays there is no need to do a perivalvular. You can always give a um, subtenons, and with that they should be. And if you're doing in topical, I would always replace or supplement it initially itself. Once I do a paracentesis, first thing I do is to put in a xylocaine or a combination of xylocaine and tropicamide, which is intracamerally available, and wait for at least 20-30 seconds. Many times I put in from one side phenocaine, and from the other side I replace it with viscoelastic. So it doesn't get time to anesthetize, go behind the iris or get into the iris root or the ciliary body and give them little more peaceful, painless experience. Because every time the fluid stops, you get the reverse pupillary block. So continuously, if the irrigation is on, only you will have the broken. Even if you get once, you can break it by lifting it up or putting viscoelastic there or putting a hook on the iris and relieve the reverse pupillary block. But each time you stop irrigation, it happens again and again. So they will. This is the I've heard. Somebody saying this is the ouch moment for patients. So every time you have the infusion on, but if you have your Centurion and your 20, 25 or 30 IOP, you may not get it that much, but then still, because it can hold more, as he was telling, it can hold more, and so it can push the iris back, and you can get that, and that painful situation should be avoided, because otherwise they'll keep on telling that it was painful during the surgery. Otherwise, it's going to be, and again, the size of the bag generally is larger, and if it is too large, 28, 29 axial lengths, then our regular torics sometimes can have a little rotation. We have not seen much nowadays because the newer modification of the lens haptics, outer and all those, and so, but it is possible some versions of the toric IOLs may rotate in this kind of lenses. That has to be told to the patient that your size is larger and you can't make an IOL which is up to the size of your bag, which is slightly larger than this. And also the centration and the sizing of your rexes, especially when you want to have a three-piece IOL. Some powers are available only in multi-piece. So if you go very low, you have to have multi-piece IOLs, and so they have to go into the sulcus sometimes. And if they go into the sulcus, they have to be captured in the rexes. And so capturing in the rexes, the sizing and the centration of the rexes is very, very important. And to the incidence of P-serent is also higher, historically. And so be very careful in chopping your cases. And sometimes as he showed, sometimes they come very hard. Even younger patients have very hard nuclei, which even though they look a little brown, it'll be very brown when you cut it open and see the inside of it. And many of them would have had some laser vision correction, and now they have become a lenticular myope, and you may not realize it. So always ask for that. Some people don't tell, they forget. We don't ask also. Some people would have been myopic. So examining the retina and getting a clue that they are myopic is very important. And look for this one and counsel them very importantly that there can be errors, which is possible. We are going by the latest and the most acceptable internationally, the formulae which are available now, as I showed you. And with that, you can have some surprises. You can always tell them that you may need even Bobby Osher, I heard him tell that two eyes of one patient both had a plus. First he had a +2, and then again he went for the other eye. That also had, and he had to exchange both. So that is very much possible, and all the newer gadgets and the precautions which you heard from Anurag are great. And if you follow that, you'll get excellent results in myopic patients also. Thank you very much.
Thank you, sir. Thank you for sharing such important practical points related to cataract surgery and high myopia. Now we'll move on to the next presentation. May I ask Dr. Divakan Misra to start his presentation?
Hi, thank you so much. Are my slides visible? Yeah.
Yes, sir.
Perfect. Thank you so much, Jiten sir, Namrata ma'am, and the whole team behind this initiative. myopia is such an important topic, and I'm so happy to see this course being conducted in such a constructive way. So I'll be talking mostly about how and what we need to look in the retina in our myopic patients. So all of these things, of course, have been talked about. The basic thing that is there is that the axial length is long. Now, what happens is with this progressive elongation of the eyeballs, there are degenerative changes that are seen all inside the eye, the sclera, the choroid, the Bruch's membrane, the RPE, the neurosensory retina. So all of these things leads to the changes that we will be discussing today. Now, pathological myopia or degenerative myopia is a type of this high axial myopia, which has very characteristic pathological changes in the fundus. Now, there's an array of changes that are seen. We'll try to take most of the common ones that are there. So most commonly that we see is something known as a myopic crescent. The pathophysiology behind is that there's a differential scleral expansion in the peripapillary area. And now there's also premature termination of the choriocapillary complex before the optic disc edge. So what we see is that there's a sharply defined concentric area of depigmentation, which is near the optic disc and where the inner surface of the sclera is also visible. So various types of these crescents have been defined, the temporal one, the nasal, the inferior, or an annular one, which is all around the disc. It has also been subdivided into scleral type and a choroidal type. Uh, Next is posterior staphyloma. Up till a very long time, we didn't have a very proper definition of it. Then Spade gave us the definition as an outpouching of the wall of the eye that has a radius of curvature that is less than the surrounding curvature of the wall of the eye. So R1 being the surrounding curvature, this is the outpouching of the staphyloma, and this curvature is smaller than the other one. So again, curtains classified into two basic subtypes, that is the basic and the compound staphyloma, and then went ahead and defined into 10 subtypes. A lot of this was not correlated on when the MRI studies were done for the same. So now we have a little simplified classification of staphyloma from type 1 to type 5. So type 1 is a wide macula, which involves most of the macula. Then we have a narrow macular one, we have a peripapillary one, a nasal one, and an inferior one. And the others, there are certain other types as well, but these are the important types that we should be aware of. Now, the whole spectrum of this myopic maculopathy has a lot of things inside it. First is the myopic choroidal atrophy, which is of two types, a diffuse one and a patchy one. So a diffuse one is where you see this yellowish and ill-defined generalized atrophy. So what we see is that there is a very marked thinning of the choroid when we do the OCTs, and only large choroidal vessels like these would remain and would be visible clinically. Contrary to this, on the patchy one, what we see is that there is a grayish white and well-defined atrophic patches like these, right? So in these areas, the entire choroid is absent, and what we see is that even the RP and the photoreceptors are absent in these areas, and the retina practically sits right on the sclera in these spaces, and all of these things are very can be documented on the OCT scans. Now, another common finding that we see is the lacquer cracks that are visible. So you can see these whitish, discrete, linear lesions on the macula. So how this develops is that there is a linear rupture of the Bruch's membrane in the macular area. And when this develops, there is also a choriocapillary damage is seen. So this might lead to subretinal bleeding as well. So we need to differentiate this from an active neovascularization process that is happening. So when this bleed is absorbed, then we see the characteristic yellowish linear lesions, right? Another differential of lacquer cracks is the myopic stretch lines, which are basically proliferations of the RP cells, right? Now, the neovascularization process, which is the myopic macular neovascularization, why we need to be aware of this, that almost 10% of high myopes have this thing, and almost 30% of these patients, if they have it in the one eye, have a 30% chance of having it in the other eye as well. So you should always be aware of these changes in myopic patients, and keep doing OCTs or do an OCT when the patient complains of any vision loss in these cases. So the OCT will classically show you this elevated lesion in the subretinal space. But one characteristic thing is that it is not, it will not be a very aggressive disease. You will not see a lot of exudative changes, or you will not see much amount of edema in these cases, right? So it will be a very subtle lesion sitting right there. On angiography, you will see more or less like a classic kind of a picture with a hyperfluorescence throughout the phases of the angiography. Uh, Contrary to the other CNVMs, on OCT angiography, we would see a vascular network. ICG is not very good in these cases, and we don't see much findings in these. So what happens is that, as I said, it is not a very active kind of a neovascularization process, and what happens is that it regresses a lot of times spontaneously and very actively leads to the scar phase, right, which is the atrophic phase. So this is covered by proliferated RP cells and observed as a dark pigmented spots known as the Fuchs spots, right? So now, after this regresses, a very well-defined choroidal atrophy develops and enlarges around this area. And it can lead to loss of vision in these patients. And as I said, almost 10% of the patients undergo this neovascularization. So there's high chances of vision loss in these patients because of this. Uh, uh, all of these changes again have been put forward in form of a classification, which is known as the International Photographic Classification and Grading System. So they have defined the myopic maculopathy with a plus component like we see in our ROP cases. So they have defined as category 0, 1, 2, 3, 4. 0 has no macular lesion. 1 has just tessellated fundus. If we see diffuse choroidal atrophy, that's category 2. If we see a patchy choroidal atrophy, then we see that is called as category 3. And if the last stage, as we discussed, an atrophic area, then it is the category 4. Along with this, if you see Lecker cracks or if you see neovascularization of Fuchs spots, then a plus lesion is added to this classification. So the course of the disease, all of these changes, intermingle almost. If you see a tessellated fundus, 10% of these could land up with diffuse atrophic areas. 19% will land up with patchy atrophy. We could see Lecker cracks, which could lead to atrophy and neovascularization. And all of these might eventually lead to the atrophic stage of the disease. So treatment, as we discussed, that it is not luckily a very aggressive disease. So whenever we pick this up on your OCT or clinical examination and angiography, so anti-VEGF, a good anti-VEGF is the first line of treatment for these. And usually, a lot of times that we see that it also responds to a single dose of anti-VEGF as well. But usually, in my practice, I like to give at least 3 injections for these patients. And it's very important to be on a lookout for these changes in the other eye as well. Coming to the next entity, that is the myopic traction maculopathy. It is also known as the myopic macular retinoschisis or myopic foveoschisis. So it is seen in 90% of high myopes along who also have a posterior staphyloma. And 50 of these percent of these patients could lead to further complications like a macular hole or a macular retinal detachment. So this in a very high myopic patient, it is very difficult to pick these changes clinically. So in my practice, and I would recommend that all of you should also do regular, OCT scans for these patients on regular intervals. Now, what happens is there are few things that have been proposed that leads to this traction maculopathy. One is the rigidity, inherent rigidity of the ILM, which can induce this traction on the retina. And retinal vessels are also implicated where they can put some tractional force and cause the traction maculopathy. Along with this traction maculopathy, we also see other changes, which are paravascular lamellar holes, vascular microfolds, paravascular retinal cysts can also be seen. We'll not discuss these in details because then it will go beyond the time. So various classification systems have been put forward. I'll discuss a couple of them. One was put forward by Shimada et al. So S0 is basically no retinoschisis. S1 is when you see an extrafoveal schisis is seen. S2 is when only the fovea is involved. S3 is fovea is involved, but not the entire macular area is involved. And S4 is something that involves the complete macula. So you have to look at all these scans that are there on your OCT to classify this. Now, another classification is uh, based on a modified classification where S0 is no retinoschisis, S1 is extrafoveal, S2 is foveal only, S3 again is foveal but not entire macular as we discussed. S4 has entire macular. Then S4D is entire macular but the foveal region is spared because there is a dome-shaped maculopathy. So that dome it locally prevents that thing. And S5D is diffuse retinoschisis, which is beyond the range of your OCT scans. So this is a modified classification that has been put forward. Now, coming to treatment options, most of these cases, classically, we have used dorzolamide and other things in this, but mostly it needs surgical intervention. So we do fovea sparing ILM peeling with gas tamponade in these cases. So it's at times, if we do not do the ILM fovea sparing ILM peeling, there could be deroofing and we could induce a macular hole, iatrogenically cause a macular hole in these cases. Another treatment option is macular buckle. Dr. Barbara Parolini and the group, they do it very actively with good results. So this is another OCT-based classification of myopic maculopathy that has been put forward, which is a bit extensive, and I'll not discuss it here. The other aspect of the presentation is about peripheral degeneration, and I feel it is more important to know these in detail because, we don't want our patients, high myop patients, to land up with a retinal detachment because we missed a peripheral degeneration which needed treatment, or the patient underwent a refractive procedure and landed up with a retinal detachment. So this is a nice paper in IGO, which all of you can review, which is about how we can screen and how we can, prevent these degenerations, especially prevent these degenerations to cause retinal detachment, especially when we are talking about surgical interventions. So now all of us know that retinal detachment is a common entity, and axial myopia happens to be the most important predisposing factor, along with the other things that we are aware of. There are a lot of, peripheral degenerations. Again, I would not like to go into a very detailed classification of these. We'll just pick a few of the ones that are important and can lead to retinal detachment. Most commonly, which I'm sure everybody is aware of, is the lattice degeneration. It has around 6 to 8% incidence, but 30-40% in myopes, right? And what we see that almost 30% retinal detachments are associated with lattice degenerations. So it's a very important entity which we should not miss on our examination, as it was discussed in the previous discussion as well. Another is the snail track degeneration, which is hypothesized to be the precursor to a lattice. And it can, though the incidence is around 10, prevalence is around 10% in general population, it could be up to 40% in myopes. So another is the degenerative retinoschisis, cystic and zonular tractional tufts, and of course retinal tears and retinal holes. Now, posterior vitreous detachment is a very dynamic process, which all of us should know about, and so this happens to be the link between the predisposing, which happens to be the link between a predisposing lesion that we have talked about and eventually leading to a retinal detachment. So what happens is that this PVD itself can also cause tears where the vitreous is very firmly adhered to the retina. That now what will it do is these tears, the vitreous will have an access through the retinal breaks and will create a retinal detachment. So we see that 10 to 15% patients with acute and symptomatic PVD are found to have a retinal tear. So a detailed retinal evaluation with somebody presenting with floaters, sudden floaters, is very important. Almost 10% of these patients will have a retinal tear. Now, if we see vitreous hemorrhage or pigments, which you can see on your slit lamp and indirect ophthalmoscope, that increases the risk to up to 70% of a tear. So most of the times, just on the slit lamp, without even doing an IDO, I can guess that this patient will definitely have some tear around if I see pigments dispersed in the vitreous. Now, so we should keep these patients, if we don't see any lesion, they should be kept under very close follow-up. And with PVDs, and at times we would see a very, patient with an absolutely normal retina in the other eye, and we see vitreous hemorrhage, which is of unknown etiology. So I try to treat these patients very aggressively because there might be an underlying break or which was caused by PVD. So there are a lot of studies that have shown that these degenerations are of course common in myopes, and we have also seen that there's a higher prevalence of these generations with increasing grade of myopia. So you have to be more concerned when you see a more myopic patient. Now, PVD is also more common in myopes and may present at a younger age than the general population as well. We have also seen that during refractive procedures, there is a lot of stressors that are there, which could cause to, all of us know that the microkeratium section ring can increase the intraocular pressure. There could be acoustic shock waves during the laser ablation process as well. So all these things increase the risk of vitreous disturbances and leading to retinal detachment. So we also see that patients complains of increased floaters after the LASIK procedures, and even the newer surgical techniques like the femtosecond LASIK, there is an increased incidence of PVD higher than compared with the microkeratome LASIK as well. So it's very important that retinal examination of myopic eyes is done very thoroughly, especially when we are planning a procedure on these patients, both preoperatively and postoperatively. And we have to prophylactically treat these, whenever we see a predisposing lesions. So how do we identify? All of us know indirect ophthalmoscope is the most important skill that we should have when we want to diagnose this. If we are not confident, we should always take help of our retina colleagues. Now we have these wide field imaging that are available, but they could miss certain findings. So even at centers where they have these wide field images, they still want to do an indirect till the aura. Again, a protocol about dilated exam, it should be done for all your patients and especially for myopes. The other patients that should also undergo dilated, if you see a one-eyed patient has history of retinal detachment in the other eye, has family history of it, and if the patient is planning any refractive or cataract procedure, patients with trauma and patients who have sudden flashes and floaters. Uh, Again, this paper by IGO has very nice recommendations in the Indian context about the management of these peripheral retinal degenerations. So these are the degenerations that definitely need treatment. There should not be a doubt. If we see a lattice degeneration with a retinal hole, if we see a horseshoe tear or a retinal dialysis, if there is a retinal hole with a cuff of surrounding subretinal fluid, we see traumatic retinal breaks. All of these lesions should be treated very actively. So some that can be considered, though not mandatory, is where you see there are predisposing lesions are present, and you see recent onset of flashes and floaters. With predisposing lesion, if the patient is undergoing any surgical or even a laser procedure, if you know that patient had RD in the other eye, patients who are one-eyed, and syndromic patients also who have high chances of retinal detachment. Now, apart from these, there are additional considerations of when you see a suspected lesion may not be a predisposing lesion also, but you might want to treat it when the patient has a family history or the patient shows an inability to come to you on a regular basis or even on an annual basis. And at times we do this for our mentally challenged patients where we might not grab them sooner. So certain lesions can be observed, but after a strict protocol of follow-up, if you see a lattice which is asymptomatic and that lattice has no break or holes, these pigmented lattices are usually safe if you don't see a break or hole. And even if you see a hole, but you see an atrophic ring around it, these are usually safe. This is a guideline that has been set for screening and prophylaxis of retinal degeneration. Basically, what it says is that you have to do a dilated retinal examination. preferably by a retina specialist. If you see a retinal lesion that is predisposing retinal lesion, then it's mandatory to barrage these with laser photocoagulation. And ideally, what these guidelines say that you should wait for 14 days, right, before planning your refractive surgery. Before the surgery, just confirm that all these areas have been lasered properly. And 2 weeks post surgery, you should repeat this examination, or you can repeat it early if the patient presents with flashes or floaters. And you should keep these patients under long-term follow-up, because there might be new areas that can come up, and we have to keep looking for these things in the other eye as well. Now, we do barrage laser for these patients, and we have seen that the incidence of retinal detachment decreases dramatically after these procedures. Now, the action is basically what it does is that there is scarring happens, and we see a stiff chorioretinal adhesion surrounding these lattices. And this helps in, taking care of the traction and prevents fluid from entering the subretinal space. So there are two modes of delivery that we usually do. One is the slit lamp, and one is the indirect ophthalmoscope. I have now mostly shifted my to the slit lamp one. It's better for your neck, and at times it's easy for the patient. Better stability and control is always there, and you will be able to make use of multi laser if that is there, multi spot laser. Of course, that is more expensive, but you might to at times use the indirect if it is a very peripheral lesion that is there and requires indentation. A lot of times we would not be able to do it for children who are under sedation. And if the patient has undergone recent surgery and you want to do laser, then for the sepsis, it is for aseptic precautions, it is important to do it. The laser settings, everybody should be aware of. The spot size is around 200 microns. Power usually is between 100 to 300 milliwatts, but it depends a lot on the machine. It depends a lot on the how the vitreous is. Are there any opacities? If there is any cataract, so it may go up. And even if the machine gets older, or if it's a faulty machine, then also the power may have to be increased. So if we do a shorter duration pulse, then it causes less pain and less spread of the laser. What we do usually is give copious amount of paracaine and jelly for these patients. We also give, if we see that the patient is sensitive, we could give a painkiller 10 to 15 minutes before the procedure as well. So what ideally we do is that 2 to 3 burns covering all the margins of the break, and it's very important to cover the anterior margin. If you are, if it is not possible to cover till ora, or the indentation is, there's a difficulty in visualizing, then always we can use cryo for these breaks. So these are the types of burns that we want, which are moderately white laser spots. So begin with faint white reaction initially, and the full reaction takes time to develop. And this faint spot may become pretty dense after a few minutes. We have to be very careful that we don't use more energy, because we might cause more breaks rather than sealing the one we are wanting to do. So we have to pick a safe spot and titrate your laser burn before you're doing this. So if we give too intense a burn, then there could be a hemorrhage. It could increase the traction. It could be more painful. And if if we cause an inadvertent burn or a hole, then we have to treat it as a new hole and laser it out as well. We should also be aware that these lasers could induce PVD in our patients. So that should also be monitored and counseled as well. So follow-up, again, as I said, it should be done 2 weeks, and after 2 weeks of this patient, and post-surgery, also we have to see the patient at regular interval, at least after 2 weeks, then a month, and then on an annual checkup, the patient should be put. So just concluding these for the peripheral degeneration part, I feel we should do dilated examinations for all our patients, and in myopics, it's a must. It's a medical legal thing. If you don't do it, a dilated exam for these patients, you should be aware of what the predisposing lesions are. document all these changes. At times you might not have a wide field, wide view viewing system with yourself. So draw a good diagram and show the patients where these lesions are, so that they feel confident, because a lot of times the patient has no complaint, so it gets difficult to counsel them. Promptly treat these lesions or get them treated. And in my practice, whenever I am in doubt, I go ahead and treat it. It's better to err on that side rather than on the other side. And please, if you're not confident, if you're not sure about one lesion, it's always better to refer and get that patient treated. Thank you so much.
Thank you. Thank you so much, Dr. Devagan, for that insightful and comprehensive presentation. I have one question for our panelists, Dr. Sangeeta and Dr. Devakan. Anybody can answer that. So you just mentioned that axial elongation is an risk factor for retinal detachment. So being pediatric ophthalmologist, I would like to ask, for those young myopes or those who are rapidly progressing in axial elongation, whether this translates to any lifetime proportional risk for retinal detachment, and whether we should follow them quite early, because usually we ask them to follow 6 monthly. Is there any objective criteria that certain numbers, or should we any pathological criteria that we should follow them frequently?
Good afternoon. I just want to get about your question. So you asked that whether the follow-up should be little closer follow-up. That's what you are meaning to ask. I didn't get your question.
Yeah. So for the young myopes, very young high myopes who are rapidly progressing, like those who are very rapidly progressive myopes, where axial elongation is noted, whether in those patients retinal detachment risk is more, and whether we should follow them, whether it should influence their follow-up interval, or
yeah, the detachment risk is more, but I would say because if there is peripheral degeneration at your, and I don't think you have to follow up a little more closely than the children already have documented peripheral retinal degeneration. Once you have a peripheral retinal degeneration and increasing myopia, for to closely monitor both the elongation as well as the peripheral retinal that is whether it is progressing, and also the quite closer look at the vitreous status as well, about the vitreoretinal interface.
Sure. And if
Yeah, I wanted to ask a question to the retina experts. How good are the, now that we will have more and more centers which will have myopia progression control programs, how good are the wide field, ultra wide field cameras in picking up these peripheral retinal degenerations? I mean, would it be good to keep them and have routine pictures, or, the gold standard indirect ophthalmoscope cannot be replaced? For screening, I mean.
Yeah, IDO is there is no replacement for clinical examination, but giving the increased number of medical legal indications now, I think the documentation of periphery is as soon as we get the child cooperative for the peripheral retinal examination. See, as we know, not all of us can have aptos, which can take 100 degrees field, and what we have in our center is a Mirante, which is only 163 degree. But still, if we get a quite cooperative myope, and we can still take up the periphery and create a montage view and keep it for a hope, and also give it to the patient as well. So that in the, I think taking a straightforward wide field may miss sometimes, and specifically ask them to look into all the directions, and taking the extreme periphery till the OA can be with the wide field. So not, but still IDO is cannot be replaced.
Sir, a sensitivity of around 75 to 80% has been noted with these,
Even
with,
in optos.
with around 200 degree of field of view. What it helps more, I feel, is counseling the patient. Because when they see that lesion, it's very easy to counsel. As I said, at times it's such a task to explain these things to them, and luckily ChatGPT and Google, everything is there. So when they look it up, and a lot of these patients come back after they have read. So I always encourage my patients to read up about these lesions. But yes, it's around 75 to 80%. indirect ophthalmoscopy cannot be, it's the number one. But again, that is a subjective thing. A lot of times in a busy OPD, we also miss these lesions. So, I mean, I think both of them go hand in hand. Right.
Especially in kids, what happens is they may have a good phase when they may cooperate with you, and you may catch them up at a wrong time. They may not really cooperate, and they may not really look where you want them to go. So
Right.
it's just
Precisely.
Absolutely. Yeah. So anybody else would like to ask, or should we go ahead with our next speaker? It is my pleasure to welcome Dr. Arpita Agarwal. She'll be addressing us on glaucoma and myopia, an area that presents both diagnostic and management challenges in highly myopic eyes. Over to you, ma'am. Kindly share your screen.
Arpita.
I think Dr.
Maybe we can ask Dr. Arpita. Doesn't
Dr. Arpita? If not, we can go
go
for
to the
an
next.
extra.
Yes,
Yeah.
we can ask Dr. Digvijay to.
Yeah. So, Dr. Digvijay, I would request if you can share your screen, and we can. It looks like Dr. Arpita is having some connectivity
Sure.
issues. Yeah.
Sure. So I'll then take up strabismus. Yeah.
Yes. So, Dr. Digvijay Singh will be speaking today on strabismus and myopia, an important and often under-discussed interface in the management of myopia. So, can you share your screen, sir?
So take it to presentation. I hope my screen is visible.
Yes, it's visible, sir.
All right. So I'll today, be covering the topic on myopia and strabismus, and I'm very happy to, see this sort of a program on myopia come along. I'm very thankful to Professor Namrata Sharma, AIOS, and Dr. Jatinder Jethani for putting this together, and for all the other speakers and panelists who've been part of it. It's been wonderful to see myopia being discussed so well and in such detail. I'm going to discuss today myopia and strabismus, essentially how they both interlink and what are the, how does the management of strabismus change in patients who are myopic, and also to some extent the vice versa. So, on the whole, if I look at myopia and strabismus, we know that myopia is a risk factor for strabismus, and it may impact the workup of a case of strabismus. It may impact how we approach it. It impacts binocularity. It can cause amblyopia. And of course, for the management of strabismus, the myopia has a role, and we'll come to each of these points in each of the slides going forward. And then there are certain special situations which are specifically, certain types of strabismus you'll see only in cases of myopia, or certain types of, ocular conditions which will present with myopia and strabismus both. So we'll come to that, but let's start with a very quick theory or a picture of what the eye looks like and the extraocular muscles look like for those of my colleagues who are, not well versed with this. But essentially, you've got the eyeball, which is here, and then you've got these extraocular muscles which are around the eyeball. And the eyeball has an equator, and these muscles, the recti muscles, attach ahead of the equator, closer to the limbus, while the oblique muscles are going to attach behind the equator. And on the sides, there are these pulleys you can see in the diagram on the right, which are these blue connective tissues, which kind of suspend the muscles from the sheath or from the orbit rather. And they also have a role to play, and we've realized that over time. So these things show a change when there is, when myopia develops. And when we talk about myopia, usually we are talking about sort of more severe forms of myopia. In mild myopia, not too much change is likely to be seen. Now, this is a very nice paper which kind of tells us the reverse, that, how is it that these extraocular muscles can in fact affect the myopia or the axial length itself. So this is a paper that came in 2018, which said that considering that the recti are in front, so that's there, but behind the equator, the two obliques, the inferior oblique and the superior oblique, pull apart, and the forces would probably help lengthen the eyeball. That's a hypothesis they put forward, and it hasn't entirely been tested, but they probably, now we know that there are a lot more factors to axial length elongation than this. But this is one of the places where the muscles were supposed to, be responsible for some amount of axial length elongation. So this is just an interesting thought to put there. But now let's see what happens. How does myopia impact the extraocular muscles? So the diagram on the left is showing two eyes, one which is a normal eye, which has got the extraocular muscles. You can see the superior rectus going on top, and these muscles are coming out from the annulus of Zinn at an angle. And in case the eye becomes myopic, there is a staphyloma that is developing, the eyeball is becoming longer, and so that can cause these muscles to actually move apart from their usual direction of travel as well as their usual positioning. And this is something that causes special syndromes such as the heavy eye syndrome or the myopic strabismus fixus, and also something known as the knobbly eye syndrome, where the bumpiness of the sclera can cause the eye to move a bit erratically, or the movements may not be smooth. So these are special situations that can get formed in the presence of staphylomas. But do understand also that there is the pulleys which are actually there in front, which are holding the recti muscle, also gets dislocated and also lose their function in cases of higher myopia, because the connective tissues are looser and the eyeball is longer. There's a stretch, and that can also cause certain amounts of deviations to change, or small amounts of forias to appear in some of these patients. And so that is again one of the theories, that there is a lot of work that has happened on this, which has discussed that it's not just the muscle itself being displaced, but the pulleys also that are getting displaced. Now let's understand that, why are we talking about strabismus in myopia specifically? So first and foremost, we know that myopia is a risk factor for strabismus. Uncorrected myopia can impair fusion. So for both eyes to work together, for good binocular vision, binocularity, both eyes have to work together, and fusion has to be good. So if there is an uncorrected refractive error, particularly a myopia, there is a tendency for that fusion to break, and so forias may get converted into tropias, which is latent squints can become manifest squints. So that's there. Of course, then there is anisomyopia, where one of the eyes is having a much higher power than the other, or a different power, which can cause anisoconia, which is the image size may change, and that again impairs fusion. Because for fusion, not just we want clear images, focused images, but also similar sized images. Typically, this would happen when the anisomyopia is more than 2 or 3 diopters and beyond. We know that the size changes roughly by about 2% per diopter, give or take. And so based on that, when there is a difference of 5% or 7% and more, it becomes very difficult to fuse for anybody. The third is that myopia is associated with accommodative dysfunction. There is accommodative lag that could be either the cause for why myopia is forming, or myopia itself may cause this accommodative lag. The need for the person or the child to accommodate becomes lesser when they're myopic. So this accommodative dysfunction also can lead to a certain problem with the strabismus. Now, the risk of, do remember that generally, but if you were to say esotropias, we think of esotropias and hypermetropia, and we tend to think of myopias and exotropia, and that is true to an extent, that the risk of exotropias are higher in cases of myopia, but you can have myopia very much even in cases of esotropia, and in fact, below 5 years of age, you can have myopic children having esotropias as well as exotropias, and so therefore that's not sacrosanct, but generally think more exotropias than esotropias. Now, the essential workup of a case of squint specific to myopia, when I talk about it, is that you must take a history of progression of the squint over time, as well as the progression of myopia over time. And this tends to happen, we tend to see this a lot with the heavy eye syndrome, and I'll come to that when we cover that. This is the squints going up over time, and so is the eyeball getting elongated and turned. The other is the history of prematurity is very important, or history of any ROP that the child may have had, any laser that the child may have got done. Any of this can cause a secondary form of myopia, which again, because of a shift in the position of the macula, or slight amount of traction, can cause the eye to appear pseudo-strabismic initially, and then sometimes even go into a true strabismus going ahead. So that's some history that you have to take. Do remember that a cycloplegic refraction is very important in all cases of strabismus. In any case, it is something that is mandated and has to be done with hypermetropes, but the same holds true with myopes. A lot of times you'll find a pseudo-myopia or pseudo-higher myopia values coming because they are using their accommodative convergence to fuse a squint or to control their squint. So you must do a cycloplegic refraction to get the accurate values. And an orthoptic workup, a workup of the ocular muscles, the near point of accommodation, near point of convergence, is important. Your fusional amplitudes for reduction, abduction, and all these do get reduced with myopia, though your near point comes even closer with myopia. So that's something that you need to work up. Binocularity is important to be able to do a binocular assessment both for near and for distance. And we use different tools. You could use a near rand dot, a distance rand dot, or Frisbee Davis distance chart, too. So anything you can use, but you have to look at binocularity and stereoacuity both for near and distance. The easy ones are, your typical diplopia goggles or the Bagolini's glasses can be easily used and they're very, very cost effective to know that. And so this binocularity workup becomes very, very important in both. And see how much the difference that can happen during a simple squint workup with glasses. This patient here who was breaking with such a large angle, suddenly with glasses is fusing very, very well, and then controllers become very good. So sometimes just the glasses itself make a huge difference. So you must always do your workup with and without the glasses, both. Let's come to the amblyopia aspect now. We know that, so between myopia and hypermetropia, or anisomyopias and anisometropia, hypermetropias, the hypermetropias would tend to cause slightly denser amblyopias than myopias generally, because myope patients, even when they're uncorrected, can still see for near, unless until the myopia is of a higher value. So for most mild to moderate myopia, you will not see amblyopia in those cases. But in cases of higher anisomyopias or myopic astigmatisms or high myopias which are not corrected, you could have ametropic amblyopia that tends to come in. The good thing about these amblyopias are that they tend to recover quickly once the child is wearing glasses, and a slight amount of therapy helps to build them up quite a bit. But it is important to, a lot of patients or a lot of people may get labeled as amblyopia just because there was one eye is showing slight anisometropia or anisomyopia. But you have to look at the retina. A lot of times, there may be something else that's going on, and that becomes a problem. And do remember that myopic children or myopic glasses have a minimizing effect. So when you look through a concave glass, the image size will become a little lesser when you see. And so sometimes, in patients who are going beyond moderate myopia, high myopia, or very high myopia, you do not expect them to actually be able to have that 6x6 vision, both from the retina perspective, as well as the glasses itself creating some optical aberrations, as well as the minimizing effect. So all that, they may end up getting labeled as amblyopia, but they may not actually be the true amblyopia in the true sense. So now let's come to, how does myopia, so we've understood so far that myopia, the extraocular muscles have some impact on myopia and vice versa. We've understood that workup is important. We've understood that myopia can cause strabismus, is a risk factor, and that it can cause amblyopia as well as a change in the binocular assessment. Now let's come to if you've got a patient of strabismus who is having a high myopia, how does that change the assessment of the squint in that patient itself? And this is something that we have seen when we assess people every day who are high myopes with exotropia or esotropias, and we find that these points, that there is a difference in the way it is assessed. So number one, the squint, as I showed in the earlier diagram, may vary with and without glasses. So always check with and without glasses. Also check near and distance both. So presence of myopia could vary the values based on whether they were using glasses and whether you were measuring for near or for distance, because in most cases they would have very good or better fusion for near than for distance. The other is that you must remember that there could be a prismatic effect of the myopic glasses. Now, these myopic glasses are concave glasses, right? So these are concave lenses in front of the eyes. You see in the diagram on the bottom right. So they have a tendency to appear, if you kind of break it up, as two prisms that are one. For near vision, it becomes a base in prism, as you can see in the image on the bottom right. And for the distance, it may become like a base out prism. But therefore, when you are assessing, and for exotropias, when the eye is outwards, then you're looking through a prism which is sort of like a base out prism, because this part of the glass would be, if you look at my face on the screen, is going to have the concave part's going to be like the apex, and the base of the prism would be here. So if I'm exotropic, it may give a base out prism effect, which means that I may actually end up seeing more exotropia than there is, because that's just the visual perception because of the bending of light. As you can see in this diagram, in this picture below that I've taken out from Dr. Kekonya's paper, that the left eye is looking straight and the right eye, which is exotropic, is looking more exotropic because of this base out prism. And you can see from the side how the concave glass is so thick in the periphery. So again, there are charts that people have given to adjust the amount of myopia and the amount of correction that you want to give. Also, in these cases, sometimes it may help to use contact lenses rather than the glasses if you want to do a more accurate measurement. In patients who are post-LASIK or patients who are wearing contact lenses, you may get slightly different values of the same amount of strabismus as compared with glasses, as we just discussed. And so you have to keep that also in mind. And sometimes, because of the very large eyeball length, in extreme cases, the concomitant strabismus may actually start appearing concomitant, even though it may not be concomitant. So those are again things that you have to be careful when you're assessing the strabismus. And a forced duction test is something that we do in cases of strabismus fixus to see how the eyeball is moving. And I'll come to that once we discuss that specifically going ahead. But do remember, myopic glasses can have a prismatic effect. Myopia patient, now the good part in a way of myopia is that it gives you an opportunity to use the myopia to correct the strabismus. So over minus glasses can help in improving fusion for exotropias or exophorias or intermittent exotropias. And while you can't do that too much, though it leads to asthenopic symptoms, but people have used that. And you could decenter the glass itself to have a prismatic effect, as you saw in the diagram just in the previous slide that I showed you. And if somebody is anyway wearing a myopic glass, incorporating a prism to that is fairly easy because they already are on glasses and they're used to it. And that becomes important. And do remember, in cases of anisometropia, you could use contact lenses, and that sometimes works very well. I had patients who will not squint at all when they're using their contact lenses and may squint when they're having glasses or when because they're probably not using the right power of glasses, or they find it difficult to use glasses. So then they end up using only the dominant eye. And so these are situations that are visible in our day-to-day practice, though you have to look for them. Now, in myopic eyes, what kind of surgical things are different when we are doing strabismus surgery as compared to a normal eye? So one, of course, your normograms may vary a bit. And so you tend to, particularly in longer eyeballs, you want to do a little bit more of recession resection. But do remember that if the exotropia is seemingly more than it actually is because of the prismatic effect of glasses, you have to be a little cautious there. But overcorrections of exotropias is something that I very often do. You have to look for patterns. A lot of these patients will end up having patterns. This is particularly due to the obliques or even sometimes the pulleys systems because they're getting lax and they're getting stretched. So both these things come out. And do remember that always look out, do remember that the sclera is thin and there's a higher chance of perforation whenever you're doing the surgery itself. So you have to keep the needle always visible as you pass through the sclera for those who are going to be doing squint surgeries in patients with myopia. And look out for the staphyloma at the back. And sometimes you'll have bands in these patients because they've had previous RD surgeries. So you have to, look at these cases on a case-to-case basis. I'll quickly come to a special situation in myopia, which is known as heavy eye syndrome. And you can see this diagram, which I've picked up from an article, but I'll also show you my own cases after this. But this is a very classic sort of diagram of a one eye where you can see that the left eye is looking inwards and downwards. And no matter in which direction or gaze the patient is moving, that eye is not moving. So this is what is known as also myopic strabismus fixus convergence. And typically why this is happening is, as we saw in the first diagram, the extraocular muscles are moving apart and there is a space in between. So if I go back to that chart, the staphyloma that you see in the left diagram, the second diagram, is causing the superior rectus and lateral rectus to move away from each other. And the globe and the staphyloma protrudes and the globe sort of gets stuck in that. And I'll show you a CT scan image of that in the next slide. So this is something that we see typically more often in females, somehow more often in people in their 40s, usually not in children, and in people who got high myopia, axial lengths more than 25 millimeters, 27 or 30 millimeters as well. And the diplopia starts to develop. And in these cases, it's a progressive sort of an esotropia and a hypotropia that develops over time, and the eyeball will not move beyond a certain point. And these cases will require, you can image to look for the protrusion of the staphyloma. And you would require a special surgery here because the two muscles have moved apart, since that is the main pathogenesis, you have to get the superior rectus and lateral rectus to come together, and special procedures described by Dr. Yokohama Yamada. Essentially, you're going to use sutures to join those two muscles together or bring them together, or you'll use a silicone band, which is known as a loop myopexy, or you will use a Jensen's procedure. So I'm not going to go into procedures since this is more oriented for the general ophthalmologist, but there are special procedures that are going to help in heavy eye syndrome. So this is a patient of mine. This is a bilateral strabismus fixus. You can see both the eyes indoors. This is something I had seen when I was at RP Center. And both the eyes are inwards, downwards. There is not much movement. And you can see on the CT scan that both the globes are elongated and there is a esotropic fixation. There is a protrusion towards the back. So just like we discussed, this is where the two recti muscles have separated and the globes have just got stuck. And this is a patient where for the surgery, you can see we've done for the left eye, a loop myopexy was done where the superior rectus and lateral rectus was combined using a silicone band, 240 silicone band. And once those two muscles came back in, the staphyloma went in and the eye started moving, and the esotropia became better. A lot of these cases, you have to combine this with a medial rectus recession as well. Another special situation now that we'll come to. And so heavy eye syndrome or myopic strabismus fixus is something that is unique to myopia and strabismus. Refractive surgery and myopia and strabismus, in fact. So refractive surgery for myopia and strabismus, there are a lot of questions that people often will come across to us, ask us, and one has to remember that there is an association between the two, and that becomes very, very important. But the first and foremost thing is always do a proper eye exam to look for presence of phorias or heterophorias whenever you're taking up any patient for refractive surgery. There could be eso or exophoria, and the patient then has to be counseled that you could decompensate further, and this could get into a manifest squint, or if there is a manifest squint, it could get worse. At the same time, there are situations where if there was a lot of anisometropia causing the squint, it gets better also after the refractive surgery. So it could go both ways, but the patient has to be counseled appropriately. And and you have to be able to document it pre-LASIK. Otherwise, they're going to come back to you and say, you did my surgery and now I have a squint, because a lot of times this may get missed if you're not doing a proper evaluation, particularly at a shorter distance. So it's important to do a proper evaluation. And the other thing is that during refractive surgery in patients who have a strabismus, you could actually have more torsion in the eye when they're lying down and seeing. So it's very important to have a registration of the iris, and they should look at the internal focus of the light so that their eyes remain straight, because particularly where there are oblique dysfunctions, the torsions tend to be a lot more. After the refractive surgery has been done, you could have, you need to reassess the squint, you need to reassess the binocularity, and do that if there was a patient with strabismus. And if at all you want to operate a case, then usually about 2 months after the refractive surgery is a good time to do that, because by then it is recovered, and a fornix incision is what we would prefer. So to take home, the messages for this presentation are that myopia and strabismus are linked in a lot of ways. The extraocular muscles can cause some part of axial length elongation. The axial length elongation can trouble the extraocular muscles in their function, and that one has to always do a proper evaluation, an orthooptic evaluation in all patients of myopia, particularly if they're going to be undergoing a refractive surgery. Then you must ensure that this is done. Certain specific issues regarding the measurement of squint and the treatment of squint, as I've discussed in a few points, are important. And as strabismologists, we do take that into account. But if you're a general ophthalmologist who is doing squint surgeries, you need to be alert to that. And finally, heavy eye syndrome, is something that can be looked at, has to be diagnosed in advance before you actually operate, because you need to plan your surgery. A simple resection will not suffice if it's a staphyloma that is protruding through the muscles, and that's important. One thing that I did not discuss was so prematurity, retinopathy of prematurity, and certain conditions of the eye also can cause myopia and myopic strabismus in a brief mention. But there are a lot more special situations that are there. But this is sort of what covers it for the general ophthalmologist. So I hope I've been able to give you a flavor of how myopia and strabismus go hand in hand. Thank you.
Thank you, sir.
Yes.
You have very nicely elucidated the issues related to myopia and strabismus. Now I would like to ask if there are any questions from the panelists, or if anybody wants to share their views on this.
I think fantastic presentation, Dr. Digvijay. It was really wonderful. And I think one of the most important aspects of myopia or myopia progression control is to do a binocular assessment. All the patients whom we are looking for treating the myopic part, we should be looking at their binocular status and also looking at their orthoptic evaluation, because if we are going to start glasses or using, if we are planning to use atropine, at least a basic workup should be done, apart from obviously the intermittent exo or obvious strabismus, as Dr. Digvijay did mention. We should at least be accustomed on doing a minimal workup. At least we should do a binocular workup to be sure that we don't miss out on any asthenopic problems which may pop up later once we start our treatment, and we may be that this was not there and this has come up afterwards.
So on this point, I wanted to ask the very similar line question that now that 0.05% low dose atropine is in the practice, and when the situation is of intermittent divergent strabismus, do you counsel parents? Do you have any tip for us that we should counsel parents something special regarding the control of IDS when we are initiating the treatment with 0.05%? Or have you observed any deterioration of controls of IDS?
So I think, yeah, I mean, theoretically, there is a subtle blur that it is likely to cause and that may potentially break the fusion. But I haven't really seen that so far in my practice. Though in any case, even when we were using atropine 0.01%, we would put that pointer out to the parents that, okay, he does have a strabismus. There might be a slight blurring of vision and you may see a little more of it. But generally, in most cases, I think I haven't personally, seen too much of that happen. Maybe Dr. Jethani would be able to put more light on that.
I think it is actually other way around. If you there was an interesting publication from Mihir and his group that they used 0.01% atropine in a group of patients, and I think there were 3 cases in which they were post surgery intermittent exotropes, and they developed esophoria and esotropia, and in 2 of them they had to actually stop the medicine. And I think there was a interesting case at this year's IMARC also, where the author was trying to present that there was a patient of orthotropia, and after starting 0.01%, patient started developing esophoria. So the explanation is pretty simple, that the accommodation which is being relaxed by 0.01 or 0.05 is obviously uneven, and patient tends to accommodate more. So it becomes like a low AC by ratio where the patient is trying to accommodate more, a hypoaccommodative esotropia kind of situation. I don't think it would, as Dr. Digvijay said, that the blur is very minimal. It should not, the child should be able to compensate for that blur. At that age, their accommodative amplitudes are quite high.
Yeah.
So I think we are running short of time. We should move on. Yeah.
So should we ask Dr. Arpita Agarwal to start her talk? Dr. Arpita, ma'am, she'll be addressing us on glaucoma and Over to you, ma'am. Kindly share your screen.
Yes, I'm there.
Yeah.
It's still coming, doctor.
Am I audible?
Yes, audible and visible. Can you just make it in a slideshow mode, please?
Yes.
1 minute. Yeah, is it visible?
Yes, all good, doctor. I'm waiting for you to change it into slideshow mode, please.
Yeah. So good
Perfect,
afternoon
perfect.
all. I'm sorry for the delay and because of the technical glitches. So I am here for my talk on glaucoma and myopia. So we all know that asymmetry is in nature, and so is the asymmetry in the disc. So these myopic optic nerves have been described by Dr. Lin as funny looking optic nerves. And whenever we look at these type of nerves, we always have a doubt, are we dealing with glaucoma? So is it really glaucoma, or it is real just the optic myopic disc we need to rule out. So why is glaucoma different in myopes? So if we look at the in myopics, the disc is altered. The optic nerve head anatomy is very much altered. The discs are usually large and tilted, and this because of this we have this. It is very difficult to detect the cupping, and the RNFL layer is very thin, so it leads to underestimation of the glaucomatous damage. The peripapillary atrophy, it usually masks the neuroretinal rim loss, and we see that the IOP is within the normal range, but we see damage and the disc and field changes are there. So also the altered blood supply to the optic nerve is there. So we have seen that axial elongation result in scleral thinning and poor structural support for retinal nerve fiber layers, which make it more vulnerable for glaucomatous damage. So there is a one study, that is the Singapore epidemiology of eye disease study, which says that if axial length is more than 25.5 and intraocular pressure is more than 20, there is a 16 times more risk of developing primary open angle glaucoma as compared to eyes with less than 23.5 axial length and with normal IOP. So there are certain red flags of glaucoma in myopic patient. If a patient is of high myopia of more than -6, there is increased chances of open angle glaucoma. With a family history of glaucoma and a disc hemorrhage and progressive myopic maculopathy and unexplained visual field defects. So diagnosis in these patients is really a challenge. Why? If you go to measure the intraocular pressure, we know that it is a stretched sclera with a low scleral rigidity. So IOP can be on the lower side despite the advanced glaucoma in such patients. If we look at OCT in myopic eyes is very limited, as there is no normative database for such abnormal disc. And due to this absence of the normative data, it's better to compare patients' scan to their baselines rather than relying on the color coding. If we look at the visual field defects in these patients, they masquerade as glaucoma by producing glaucomatous patterns of visual field abnormalities like paracentral scotomas, nasal steps, and arcuate defects. The supratemporal visual field defects are often seen in this tilted disc. So also we see large blind spots in high myopes. Myopic visual field defects are non-progressive in nature, we know this. So in all these patients, there are false positives also, and sometimes we misdiagnosis. Both are common. So what is the important thing in these patients? So baseline is the key. So we should take baseline intraocular pressure, baseline Humphrey visual field, disc photos, and OCT scans, because this will set us a benchmark, and we will do all the follow-ups comparing this baseline. So what is important in these is not how the nerve looks, but it is important how different or same it is from before. It is more important. So the main differentiator in these patients is progression over time, which we see in glaucoma. And if we see a stable findings, there are no changes over a period of years, then it is most likely we are dealing with myopic disc. So if we look at separately how we treat these patients, if we look at this, the glaucoma that the axially myopic
Dr. Arpita, sorry to interrupt, ma'am, but your, I think, voice is
not true myopics. So when we do these patients, the stems can stretched, and so there is a stretch.
There's something wrong with the connection.
And there is difficulty analyzing it, and sometimes we end up doing premature detachment in these patients. Now, if we look at this in trabeculectomy, what is important while doing the trabeculectomy such as we should always be very gentle, and as the flaps are very thin and it can tear easily. Yeah. Am I audible?
Yes, doctor, you're clearly
Hello.
audible. Yes, you're clearly audible. The video doesn't have any sound in case that is a question. Dr. Arpita, the video doesn't have any sound.
Can you hear me?
Yes, doctor, we can hear you.
Can you hear me?
Yes, doctor, we can hear you. Can you hear me?
Hello. Okay. So should I start?
Yes, but the video, does the video have any sound?
No, the video doesn't have any
Yeah,
sound.
you are audible. You are clearly audible. You can continue, please.
Okay, sure. So if we look at the surgical pulse in trabeculectomy for myopic eyes, the scleral flap creation should be very gentle. Why? Because it is we are dealing with thin sclera, and the flap what we make should be thicker, and it should be slightly larger and thicker, and we should use only low concentration of mitomycin C and for a very short period of time. So here's a small video where I have. Where you can see the flap is quite thick and large, and we can see we should hold it properly, and it should be very gentle, and we should avoid using a toothed forceps in these so that you don't tear the flap. So this is the mitomycin should be applied for a very short time, and in a very low concentration. So this is one of my patient. I did this was myopic as well as having congenital glaucoma. The eye operated right eye. Right eye, I felt the prognosis was good, but left eye I was not very hopeful. But anyway, I did the surgery, and see after a month later, and now the patient is now 6 years old, and he is having quite clear corneas. So coming to surgical pulse for glaucoma and implant surgery. So we should plan to make take smaller plate implants in these patients, in myopic patients, and non-valve implants. If we are putting, it should be the ligature or stenting should be done to avoid overfiltration and hypotony. We should use short sutures and avoid deep passes because of the risk of scleral perforation. And post-operative hypotony, choroidal detachment, and maculopathy is quite common in high myopics. And these patients, lifelong follow-up is needed. Why? Because these eyes may show delayed erosion of the tube or shifting of the implant due to scleral thinning or globe elongation over time. So there's a small video of Adi valve implant. This is one of the patient I did Adi valve implant surgery in one eye and AGV valve in the other eye. So this was a very high myopic patient, and I was very skeptical when I operated this patient. But there was the pressures going was 40 millimeters of mercury. So this is Adi valve. I am putting the lateral rectus, isolating the lateral rectus and the superior rectus. Then this valve was placed between the both the superior recti and lateral recti. Now the bite should be small, and it should be it should not be deep. The Prolene suture was put in both the eyes. The tube was then ligated as it is a Adi implant, not the valve one. And we test the patency and make this venting slits in the tube. Again, the tube patency was checked, and we can see that it is properly ligated. The tube was cut. We should take care that the tube should be long enough, because we know these are high myopic eyes. The AC is quite deep, and we know with the growth of the eyeball, the tube erosion can also occur. So we can we can take a longer tube to avoid tube erosion. This was stitched with sclera with the help of 1009 ohm suture, and then this tube was covered with a scleral patch graft. So this was the patient. I did AGV in one eye. See, you can see the bleb. The this is in the shape of a glaucoma valve implant. This is quite diffuse bleb. So if you 1 year follow up, I could see the right intraocular pressure in the AGV valve eye, it dropped from 39 to 19, and in the other eye with the Adi valve, it dropped from 34 to 12. So the take-home messages are: whenever you see a myopic disc or you have a doubt of glaucoma, check. Don't give your don't ask your assistants to do intraocular pressure or gonioscopy. You yourself should do it, because it is going to last, because you are going to make all the comparisons in future with the intraocular pressure, baseline intraocular pressure, gonioscopy, and disc photos. So all baseline should be done and documented properly. Longitudinal follow-up is important in these eyes because it helps you to distinguish progressive glaucomatous damage from non-progressive myopic abnormalities, and we should monitor visual fields more than the structural scans. So OCT is the visual fields are more important than the OCT, and you should always document the disc every time you look at it. And lifelong follow-up is needed for such patients, because not only just for glaucoma but also for at-risk retina. And we should customize our treatment, and one size doesn't fit to all. Thank you.
Thank you so much for the wonderful talk, madam. And I would request, can you hear me? Yeah. So I would request Dr. Amit Porwal to kindly give his expert comments on this topic. Yeah.
Hello.
Yeah. Yeah, Arpita, your talk, it was audible to all of us. It was an excellent talk. Arpita has covered everything from diagnostic to surgicals, what all precautions and what all dilemmas one can have in management of glaucoma coexistent with myopia. So only few I would like to say is that all high myopia patients should be regularly followed for the intraocular pressure checkup, and also the repeated OCT and fields. And as mentioned, the myopic field defects, they will be more stronger and they won't be progressive, whereas glaucomatous field defects can be progressive. So the depth of the visual field loss will be more definitive in myopia, whereas it will be progressive in glaucoma. So this one thing I should remember. And when it comes to the surgical part, especially for glaucoma patients, Arpita has mentioned all the points very clearly, except for one point which I think she forgot. Whenever we cauterize the sclera, the bleeders, we should not do excessive cautery when we are cauterizing the bleeders, because as it is, the sclera is thinned in high myopes. And if you do excessive cautery, then when you create the scleral flap, there will be a lot of shrinkage. And when you are suturing the scleral flap, there will be buttonholes because of the shrinkage. So you have to be very careful when you are creating the scleral flap and when you are going to cauterize the sclera. And as she mentioned, you can use a tooth for plain forceps, or you can also use a Hoskins forceps. But avoid using a one tooth forceps because that will cause again a flap perforation. Other thing is always better to do under a subtenous block. Perivelar block has its own complications in case of high myopes. So you can use a subtenous block. Mitomycin, you have to be very, very careful when you're using mitomycin. It is better to avoid mitomycin in high myopes. And if at all you want to give, reduce the exposure to not more than 1 minute. Because you never know when this mitomycin related toxicity on the sclera can come, and there will be a melt which we will see in the long run. So rest everything she has covered very nicely, and regular follow-ups of these patients for glaucoma evaluation is very, very important. So that's all I wanted to add for this, and I think we are already late in this webinar. And thanks a lot, Jitu, Jiten Jitani, and the whole team who's behind this. It's an excellent webinar, which very informative.
Thank you so much, Amit. Thank you so much, Dr. Arpita. And just take give a small this thing that MCQ link for those who have registered is available in the chat box, and you have to even if they do the 70% of the questions, or if they are right in 70% of the questions, they would get the certification for this. Please continue. If there are any questions or anything which Abhilasha wants to put.
So one of my colleague has put the question that in pediatric patients, especially high myopes, we often lack a reliable normative OCT database. So in late teens patient, what clinical or investigative parameters do you rely on most for glaucoma evaluation or screening? Like those 14 years, 15 years.
So normative database is not there for what we have for OCT, especially the Zeiss one I'm talking is. Zeiss we have normative database from 16 years, and OCT for the OCT, and for visual fields we have from 18 years. So before that, whatever investigations you do, there's no normative database, but at least a baseline, as Arpita has mentioned, you can have a baseline OCT and fields which will show you don't look at the normative database comparison. Just look at the absolute values what are there, and whether it is normal or whether they are thinned out. And clinical acumen is very, very important when you're dealing with these patients. Basically, the discs are dilated. There will be a peripapillary atrophy also, especially in these high myopes. But you have to deal it clinically. And young myopes, young high myopes, it is not so common to see the peripapillary atrophy at such a young age. So it won't be much confusing. And IOP is one of the important factor which we can take into consideration. Again, when if it's a normal tension glaucoma, that's not the age group which we look for.
Right. Agreed. So I think today's discussion have beautifully highlighted that effective myopia management is beyond progression control only, and it demands vigilance, early recognition, and truly holistic approach. I extend my heartfelt thanks to all the eminent speakers and panelists for sharing this expertise so generously. And I request Dr. Jethani to give his closing remarks for today.
I think excellent webinar, and thank you so much. Monday becomes a very busy day. And first of all, thank you so much, Dr. Abhilasha and Dr. Chinmay, for taking out time, because on Mondays the OPDs are very, very harsh, and so it becomes very difficult for all of us to come forward, especially in the afternoon time. So thank you so much, and a very big thanks to all the speakers, Dr. Arpita, Dr. Digvijay, Dr. Devakant, and Dr. Anurag. All of you I know you have a very busy practice, and taking out time always is difficult. And not to forget our experts, Dr. Sangeeta, Dr. Amit, and Dr. Kirti Singh, Dr. Meenu Mathan. So thank you so much, everybody. Dr. Love, for taking out time and contributing for this, and a big thanks to Namrata ma'am for giving us all opportunity to start this certification program, to start at least making some noise on myopia progression. So thank you all. And the next module would be module on the future options in myopia. So I think that would be pretty interesting. What is there in future for myopia control? So looking forward everybody to join that. Thank you so much.
Thank you. Thank you so much, sir.